On this lesson, Unit 1B, we're going to discuss how does dyspnea originate. As respiratory therapists, we need to understand why our patients are dyspneic and what causes the lung problems so we can better know how to treat their lung conditions. Dyspnea may occur in conditions where ventilation is stimulated by lactic acid production at low levels of exercise, and this can be caused from deconditioning, anemia, which we know deals with low blood cells or hemoglobin, and low cardiac output states. A patient having a low cardiac output state, they will appear very fatigued with very little activity. They're always tired due to their heart not pumping correctly. You may even see that they have low blood pressure or high blood pressure, and they may even on monitor have a few arrhythmias. All of these things could cause the patient to be tired and short of breath. Tools and procedures utilized to measure dyspnea. First, we're going to evaluate by assessment of the airway, breathing, and circulation. This is going to help us determine the patient's cardiopulmonary status. Secondly, we're going to conduct a medical history and physical examination. So we're going to do like a medical interview. We're going to ask questions like, do you smoke or use any type of tobacco products? Ask the patients about their cardiac history, pulmonary history, whether or not they have asthma, emphysema, chronic bronchitis, COPD, pulmonary fibrosis, and so on and so on. You're then going to take time to listen to the patient's lungs to see if they have any wheezing, congestion, rhonchi, crackles, which can explain why the patient might be having problems with their breathing and shortness of breath. You're also going to do some tests, whether it's ordered by the doctor or just tests you're going to check out and see what the results of in the electronic health record. And this can include CBC, their arterial blood gas, pulmonary function tests, chest x-ray, EKG, and all other types of blood work that can be helpful in determining why this patient may be suffering from dyspnea and shortness of breath. It is important to ask key questions that relate to the persistence and variability of the system aggravating factors. Those factors can be what affects activities of daily living, ambulation, and position. We want to know how this affects the patient's life doing these things. And also it's important to determine the two different factors of dyspnea. The first one is called intermittent dyspnea, which relates to asthma or heart failure. These are things that are more acute in nature. Asthma isn't all the time. It's just when they have factors or environmental issues that affect their lungs that cause them to be short of breath or have tightness and wheezing. Heart failure also deals with failure in the heart, and that can also be due to water backing up in the lungs and then going into the heart due to right heart failure. The other type of dyspnea is persistent dyspnea, which relates to COPD or interstitial fibrosis. Those conditions, a lot of the patients are always short of breath, and that's due to their chronic condition. And these are things that happen over time. Pulmonary fibrosis can be from environmental factors, if the person worked in a mine or had exposure to chemicals. And COPD, we know, is a combination of several lung conditions. It can be is emphysema, asthma, or chronic bronchitis. Usually, if you have two of those conditions, you usually have what we call COPD, a combined condition. What are key signs and symptoms obtained through a medical history and physical examination that relates to qualifying dyspnea? In your patient interview, your patient may report that they have what we call nocturnal dyspnea, which can be related to asthma, congestive heart failure, gastric reflux, and nasal obstruction. The patient may also report dyspnea occurring with exercise in relation to exercise-induced asthma, COPD, and heart failure. They also may report dyspnea occurring independent of exercise as a result of allergy and psychological emotional problems. And they may also report dyspnea as a result of psychogenic dyspnea, which should be suspected when symptoms of dyspnea vary greatly and is unrelated to any type of physical activity. Psychogenic dyspnea can be related to emotional stress, just anxiety. This patient may be one that needs Ativan or Valium just to kind of keep their nerves calm. they have irregular breathing, and you get reports in the hospital. Maybe the nurse may call you and say, hey, this patient's having shortness of breath. And you check them over and completely listen to their lungs. Their lungs sound fine. You check their sats with the pulse ox. Their pulse ox is fine. But when you look at the patient, they just look like they're just struggling to breathe. And a lot of it's in relation to anxiety and mental stress. Maybe they didn't get their pain meds, or maybe they're just worried about something. So they cause themselves to kind of go into like a panic attack, which can affect their breathing as well. And you'll see them, they become lightheaded, they may hyperventilate, they may cause their heart to breathe funny, and they may even pass out. A few other factors that may affect dyspnea or breathlessness. One of the most common factors throughout the United States, of course, is cigarettes. Food can cause patients to be breathless. It is known that if a patient eats foods that can cause their CO2 levels to go up, it can cause their body to be acidic, and it can make them short of breath. One example of that will be broccoli. Medications can cause a patient to be dyspneic and short of breath. Allergens, of course, can affect their lungs and make them short of breath. Weight gain and obesity. If a patient is extremely overweight, any type of movement, even just to walk to the bathroom, can cause them to be short of breath and huff and puff. And sleep problems and disorder. If a patient has a breathing disorder at night that they're not aware of, and they wake up out their sleep and they're breathing fast and they're short of breath and their heart is racing, they may have what we call obstructive sleep apnea that is undiagnosed, and it can cause them to be dyspneic and short of breath as well. So doing a physical examination may provide vital clues for the determination of the severity of the symptoms of dyspnea and lung disease. So we're going to check out and observe the patient's respiratory rate, heart rate, blood pressure, obesity, whether or not they're within what we would call ideal body weight, posture, use of accessory muscles, pursed lip breathing, their emotional state, whether or not they're having anxiety or anxiety prone, abnormal chest expansion, like scoliosis, cough, JVD, which deal with jugular vein distension, pedal edema, which will let you know whether or not the patient is retaining fluids, and digital clubbing. To determine the patient's level of dyspnea, we can use what we call scales to quickly identify the patient's level of dyspnea. So a number of scales may be used to quantify shortness of breath. One of the first scales that we're going to talk about is the modified Board scale. It's a scale that may be subjectively rated on a scale from 1 to 10 with descriptors associated with the number. The second scale that we're going to look at is called the MRC breathlessness scale. This scale may suggest 5 grades of dyspnea based on the circumstances in which it arises with the patient's activity. MRC, in case you're curious, stands for Medical Research Council. So the scale that's on this page is called the Modified Board Dyspnea Scale. It assesses the degree of dyspnea on a scale of 1 to 10. We use this scale mostly with our patients that have COPD and asthma. The nice thing about this scale is assessment is quick and easy to obtain from the patient. It gives us subjective information, so the patient's going to tell you how they feel as far as their level of dyspnea due to bronchospasm. This scale is commonly used to assess dyspnea in pulmonary rehab areas, emergency rooms, and urgent care clinics. The scale on this page is called MRC Breathlessness Scale. It's a scale that is used to determine the best number to fit the patient's level of activity on a grade of 1 to 5. The nice thing about this scale is it's quick and easy to obtain just in a few seconds by asking the patient a few questions, or if the patient is telling you how they feel. So the patient may tell you something like, I am too breathless to leave the house. When you look on the scale, the patient will fall under what we call grade 5, which talks about being too breathless to leave the house or breathless when undressing, which is one of the more severe levels to be at with your dyspnea or shortness of breath. Another example would be if you ask the patient, are you short of breath when you're hurrying to walk on a level or walking up a slight hill? So when you look on the grading scale, that would be considered a grade 2, and that's where the patient will fall under. And it's not one of the more severe levels, but you can tell that they're having a little trouble and they definitely need to have some type of intervention. A number of labs may be helpful in determining the cause of shortness of breath. A blood test called D-dimer can be done to rule out pulmonary embolism, also called PE. That's when a clot lodges into the lungs and causes the patient to be short of breath. Low level of brain natriuretic peptide to rule out congestive heart failure, also known as CHF. Natriuretic peptide deals with excretion of the kidneys with high levels of sodium into the body. So if you have a low level of brain natriuretic peptide, that's usually a sign of congestive heart failure. However, if you have a high level of brain natriuretic peptide, for supportive diagnosis due to advanced age, renal failure, acute coronary syndrome, or maybe even possibly a large PE. Another test that can be done commonly for respiratory therapists at least is arterial blood gas. It can be obtained at rest and also at peak exercise. As respiratory therapists also we will want to monitor the pulse ox level to check for desaturation during exercise, to assess the patient's response to whether or not they need supplemental oxygen during exercise or exertion, or whether or not they do not, or maybe even need adjustment. And lastly, we can also check out the chest x-ray. We'll do a chest x-ray to confirm or rule out pulmonary pneumothorax, pulmonary edema, or even pneumonia. This ends this unit 1B, Part 1.